Welcome to the class. Now the next topic is a fetal circulation. We begin with our code master MRCOG with concept oriented clarity. Now, what is the basic concept as far as fetal circulation is concerned? The fetus does not use the lungs for the oxygenation. What is the organ which is responsible for oxygenation? It is the placenta. So the placenta acts as an organ of gas exchange, nutrition, and the waste removal. Circulation is designed to bypass the liver and the lungs. So there is a bypass at the level of the liver, at the level of the lungs. Okay. So what are the unique features of the fetal circulation? There is a presence of three physiological shunts. We have seen there are three shunts. One is at the level of the heart, one is below the level of the heart, one is above the level of the heart. Okay. So right ventricle pumps the most of the blood. The pulmonary vascular resistance is very high. Systemic vascular resistance is very low. Okay. This is what is the peculiarity in the fetal circulation. Right ventricle will pump the most the blood. Pulmonary vascular resistance is high. Systemic vascular resistance is low. What are the components of the fetal circulation? The placenta plays the major role, and the vessels through the umbilical cord. You have two umbilical arteries and one umbilical vein, that is the left umbilical vein. Then you have fetal heart and the fetal vessels. Okay. Now let's see how is this particular flow. Okay. From the placenta, you have got the umbilical vein. They will carry the blood, and through this ductus venosus, which is the bypass for the liver, it will drain into the IVC, inferior vena cava. Through the inferior vena cava, it will go into the right atrium. Then through the foramen ovale, it will go into the left atrium. Then it will go to the left ventricle. Then it will go to the ascending aorta. Then to the brain and the upper part of the body. Okay. So most of the oxygen-rich blood goes to the brain. Okay. So this is the thing which is happening in the fetus. There is oxygenated blood from the placenta enters the right atrium via the IVC. Okay, via the IVC, it will enter into the right atrium. There is a foramen ovale which allows the oxygenated blood in the right atrium to reach the left atrium. So through the foramen ovale, it will go into the left atrium. Okay. Then there is a ductus arteriosus connects the aorta with the pulmonary artery, further shunting the blood away from the lungs and into the aorta. So this ductus arteriosus, which is pattern, that will shunt the will bypass the liver and bypass the lungs, and it will go into the aorta. Then mixed blood travels to the head and upper part of the body and back to the placenta via the aorta. So these are the things which are happening. Here, from the placenta, blood arrives via the umbilical vein, and the ductus venosus shunts the oxygenated blood from the placenta away from the semi-functional liver. So there is bypass at the level of the liver. Okay. So umbilical vein will carry the oxygenated blood, and there is a bypass at the level of the liver, and it will go into the IVC. Okay. Now, how does the deoxygenated blood will travel? So from the superior vena cava, it goes into the right atrium, then it goes into the right ventricle, then pulmonary artery, then ductus arteriosus, then descending aorta, umbilical arteries, and then it will go to the placenta. Okay. So what are the shunts that we have already discussed? There are three shunts. The ductus venosus, it connects the umbilical vein with the IVC. It bypasses the liver and allows the rapid delivery of the oxygenated blood. Then there is at the level of the heart, you have the foramen ovale. There is opening between the right and left atria, allows the blood to bypass the lungs. Its flow is from right atrium to the left atrium. Then third is the ductus arteriosus. It connects the pulmonary artery to the descending aorta. It diverts the blood away from the lungs. It is maintained by the prostaglandins and the hypoxia. Okay. Then what are the oxygen saturation differences? The highest will be the umbilical vein because it is coming from the placenta, and the placenta is the main site of the oxygenation. So the highest will be in the umbilical veins, moderate will be in the ascending aorta, and lowest will be the umbilical arteries because they are carrying the deoxygenated blood. Okay. Now what is the transition which is happening at the birth? At first breath, the lungs will expand, the pulmonary resistance will reduce, the systemic resistance will increase, and there is a functional closure of these particular shunts. So what happens at birth is the functional closure of these particular shunts. Okay. So this is the difference oxygen saturation because 80-85% is the oxygen saturation in the umbilical vein. Then ascending aorta will have somewhere 60-65, that is moderate, and the least is in the umbilical artery, that is 50-55%. Okay, so this also you should remember the oxygen saturation in the various vessels. Okay, now postnatally, what is happening? These shunts are getting closed. The fetal structure, that is the ductus venosus, will become the ligamentum venosus. These are all SBS. Okay, the fetal structure and their adult remnant. Okay, please remember, ductus venosus will form the ligamentum venosum, foramen ovale will form the fossa ovalis, ductus arteriosus will form the ligamentum arteriosum, then umbilical vein will form the ligamentum teres hepatis, and umbilical arteries will form the median umbilical ligaments. Okay, the umbilical artery will form the medial umbilical ligaments. So these are the fates of the fetal structure which you should remember. And second, this ductus arteriosus, sometimes it may remain patent, and in the fetal life, this patency is important. But there are certain heart diseases in which they are called as ductus dependent. The survival will depend upon the patency of this particular ductus. Okay, so which are those? They are the TGA, pulmonary atresia, hypoplastic left heart syndrome, and severe coarctation of aorta. These are the ductus dependent heart diseases. In these conditions, blood mixing through the ductus arteriosus is life saving. Therefore, we use prostaglandin even to keep this particular uh, this shunt open. Okay, so TGA, pulmonary artery atresia, hypoplastic left heart syndrome, and the severe coarctation of aorta. So these are the different heart diseases in which this ductus arteriosus is going to be very important. Now, failure of the ductus arteriosus will lead to the PDA. The right to left shunting is important for the fetal survival in the fetal life, and the prostaglandin E1 is used to keep the ductus arteriosus open in congenital heart disease such as what we have seen: TGA, pulmonary atresia, hypoplastic left heart syndrome, and the severe coarctation of the aorta. Now they are also asking the timing of the closure. Okay, so please concentrate. So when does the foramina ovale gets closed? So the functional closure happens at birth, while anatomic closure will take 3 to 6 months, and the adult remnant is a fossa ovalis. So foramina ovale, the functional closure will happen at birth. Then anatomical closure will take around 3 to 6 months, and adult remnant will be fossa ovalis. Then ductus arteriosus. Ductus arteriosus will get closed in 24 to 48 hours, and anatomical closure will happen in 2 to 3 weeks. It will remain as a ligamentum arteriosum. Then ductus venosus, within hours there will be functional closure, and in 1 to 3 weeks the anatomical closure will be there. It will remain as a ligamentum venosum. The ligament umbilical arteries will close functionally in minutes, and anatomical closure will take 2 to 3 months. It will remain in the adult as a medial umbilical ligaments. Then finally the umbilical vein, there are only one. Okay, this it will take days for the closure and weeks for the anatomical closure. Functional closure will take days, umbilical closure will take weeks, and it will remain as a ligamentum teres hepatis. Okay, so that is what is the fate in the adult. Okay, now they can ask you certain things. The oxygen tension is high, and high oxygen tension will lead to the ductus arteriosus closure. The prostaglandins keep this ductus open. Okay, and this patent foramina ovale is not same as atrial septal defect. Okay, there is no tissue deficiency in patent foramina ovale. There is a difference between the two, that also we will discuss. PDA is common in preterm infants. NSAIDs will promote the closure. Okay, so this indomethacin will promote the closure. Patent foramina ovale is, there is a door but it is not sealed. Okay, so patent foramina is nothing but the door is present but it is not sealed, while atrial septum defect, the wall has got a hole. Okay, in atrial septum defect there is a defect in the development of the septum and the wall has got a hole, while patent foramina there is a door but it is not sealed. Okay, so patent foramina ovale is not a true atrial septal defect because there is no deficiency of the septal tissue. It is due to the failure of the postnatal fusion of the septum primum and the septum secundum. So there is no fusion of the septum primum and the septum secundum. That is why this patent foramina ovale remains. So that is not a true ASD. Okay, so the true ASD will be ostium primum or ostium secundum type of ASD. So atrial septal defect, what is the embryological basis? In atrial septal defect, there is a true defect in the atrial septum, and this may be due to excessive resorption of the septum primum or inadequate development of the septum secundum. Okay, so actual absence of the septal tissue is there. So key feature is that there is a permanent hole in the atrial septum, there is a continuous left to right shunt, and there is increased pulmonary blood flow. What are the types of ASD? Ostium secundum, ostium primum, sinus venosus, and the coronary sinus defect, out of which the ostium secundum is the most common type. So you should know which type of ASD is most common. It is the ostium secundum. Okay. Now this patent foramen ovale is formed by the septum primum, which has got a valve-like action, and the septum secundum. Okay. So after birth, there is increase in the left atrial pressure, which will push the septum primum against the septum secundum. So in patent foramen ovale, what happened? This septa failed to fuse, and there is no tissue which is missing. So in patent foramen ovale, there is no tissue which is missing, but there is a failure of the fusion. Okay. So key feature is that flap-like opening is there, potentially communication only, usually closed at rest, but it can open transiently with increased right atrial pressure, such as coughing, valsalva, pulmonary hypertension can happen. Okay, and clinical importance, mainly it may be asymptomatic. It can cause paradoxical embolism, then cryptogenic stroke, and there is no continuous shunt. In PFO, patent foramina ovale, there is no continuous shunt. Okay, so this is what is the difference between the patent foramina ovale and the atrial septal defect. So patent foramina ovale, it is functional, while atrial septal defect is a structural. Septal tissue is present in PFO, while it is deficient in ASD. PFO is because of the failure of the fusion. It is the ASD is because of the failure of the formation or excessive resorption. Okay. Then shunt is intermittent in PFO. There is a continuous shunt in the ASD. Direction of the shunt, generally at rest there is no shunt, but in ASD there is a left to right shunt. Murmur is absent in PFO, while in ASD you get a murmur. Pulmonary hypertension is not seen with PFO. It is common if not treated in ASD, and PFO will not require a closure, while ASD will require a closure. Okay, so that finishes the development of the cardiovascular system. Thank you.